Good evening, everybody, and welcome to our webinar entitled Mastering Your TRIOS Scanner. Thanks for joining us this evening. My name is Mark Barry, and I look forward to taking you through the webinar this evening. So I'm the Managing Director of ESM Digital Solutions. We set up our business in 2007, and in 2012 I had the privilege of going to Copenhagen to get trained up on using tree-shaped TRIOS, the very first version, just at the time when it was about to be launched. So August 2012, so that gives me 10 years of scanning experience, and over that time we've scanned several hundred, we've trained several hundred clinicians, installed over 250 units, and the technology has taken me to lots of exciting places and lots of exciting customers around the world. A little bit about our business, ESM Digital Solutions. We like to present ourselves as being a truly open partner delivering truly open solutions. We've been working with 3Shape since the very first day of business, and since then we've taken on other products including ELOS implant components, Formlabs 3D printers, and DG Shape milling solutions as well, so that we can offer a full end-to-end digital solution to our customers. A little overview about this evening's presentation. So ultimately, it's all about nuggets. I'm hoping that I'm going to be able to pass on some nuggets to you all. Maybe you'll learn lots. Maybe it'll just be a refresher. Maybe it'll be an opportunity for you to see how the system works, maybe in a different light. But ultimately, by the end of the presentation, I hope that you've got some good take-home points to take with you as you enjoy TRIOS. So to start with, we're going to look at the textbook scan strategy. We're going to talk about the patient experience, managing mobile tissue. That tends to be a bit of an issue for a lot of people. So we're going to try and understand that a little bit more and get some techniques in place for that. We're going to try handling challenging scan situations, and then we're going to dig into some of the software features as well, the trimming tool, the lock tool, HD photos and shade, etc. So just to get a deeper understanding of the tools. Sometimes people start off scanning and they focus on scanning, and that's where it starts and that's where it ends. So maybe there might be some little nuggets here as well that will help you take onto your scanning game. And then finally, we'll look at patient-specific motion, and again, help understand how to use that and utilize it to its best, and again, incorporate it into your day-to-day scanning. So let's talk about the patient experience. What can the patient expect? Well, first of all, we hope that the patient will expect an excellent, well, it will expect, and we hope to deliver an excellent scanning experience. I always talk about the chair-side manner. We always have a little chat with patients before we're going to scan, tell them what it's about, what to expect. So number one, the tip is going to be warm. It's approximately 42 degrees. That's nothing to be concerned about. A cup of tea is typically 60 degrees or so. So whilst the tip might feel warm in the mouth, it's at a very modest temperature. There will be a slight vibration sensation, and the software will also make a clicking noise. You tell the patient about this, they're going to be fine with it. Sometimes we do experience that if you don't tell the patient what's happening during the process, that they sometimes feel maybe, yeah, the tip was a bit warm, or they didn't like the vibration, they weren't ready for it, and so on. A key thing to scanning is getting the screen into the right position. So here we have Freddy, our phantom head, and I've got the move unit set up right beside Freddy. Now in this case, in this situation, the patient is sitting upright, and we've got the screen sitting over the patient's left-hand shoulder, and we're standing to the patient's right-hand side. It's really key that we can see the patient whilst we're scanning, of course, but I'd argue it's nearly more important that we have a good, clear line of sight of the screen as well. So we can see the screen, we can see the image being produced, and of course we can see the view at the lower right-hand corner. So the patient and the screen are in the same line of sight. It's really important that you avoid awkward screen positions. Of course, with Move Plus, we have the luxury of being able to put the screen exactly where we want it, whereas if it's a pod with a laptop, some consideration should be given as to where that laptop's going to be positioned, whether it's on a bench, a worktop, or indeed on a trolley, and that can be wheeled up to the chair. But it's important that it's in the correct line of sight. I often work with the mantra that your comfort relates to the patient's comfort. If you are comfortable whilst you're scanning, the patient will be comfortable. And there's a couple of things we're going to talk about now in a moment. So one of the key things is stability. So in this case, I'm holding the scanner with my right hand and I'm using my left hand. The left hand is just as important. The left hand, we use it for stabilization. So you can see, let's get the little laser pointer here. So you can see I've extended my fingers onto the patient's jaw. I've put my index finger in to retract the cheek, and then I'm going to use that index finger as a guide. So I'm supporting the scanner on my index finger there. So the left hand serves three purposes: to stabilize, to retract, and to guide. And it means if we've got the scanner in the patient's mouth and we're nice and stable, we're in control. And it means that you can spend more time looking at the screen rather than looking in the patient's mouth without the fear or consequence that the scanner will be moving around the place. So it's important you are comfortable. It's important to hold the scanner in a manner to minimize big muscle movements. So in this manner here, and I have a couple of slides now in a moment, I'll show you, but by holding the scanner from underneath in our hand, we can hold it quite loosely. And it means that all of the movements are really controlled by our fingers and our wrist. Big muscle movements. We don't want to have to lift our shoulder and our elbow whilst scanning, because if we are applying those big muscle movements, ultimately those movements will be transmitted into the patient's mouth, and the scanner tip may dig into the sulcus or into the floor of the mouth, or nudge the tongue and so on. Don't obsess over the button. Very often we see people, they feel there's a button on the scanner, we need to keep our finger on it. That's not necessary. You just need to push that button once when you start scanning. So feel free to roll the scanner in your fingers. And as I said, we use the opposite hand to retract, guide, and stabilize. You're all dentists. You've been using instruments in the patient's mouth since day one. So think of a finger rest. The scanner is just another item that should be utilized with a finger rest technique. So here's some do's and don'ts. So in this situation, I'm holding the scanner from underneath and like a pen grip style movement. And you can see here, I'm very comfortable. My arm's in a comfortable position and I can sweep around, do the occlusal surface. And as I come around, do the lingual surface, for example, I can tip the scanner up, and I'm tipping it up with my fingers. My arm, my wrist staying in the same position. If we look at the image on the right-hand side, when holding the scanner from the top, again, that might be a natural way to hold the scanner, but in order to get that kind of angular movement to tipping the scanner up when doing scanning the lingual surfaces, you'll see I have to lift my whole arm up. If my arm lifts up, my elbow lifts up, and it's going to impact my shoulder as well. So it can be quite uncomfortable with time, and as I say, that discomfort can sometimes translate into the patient's mouth as well. So we tend to be in a lot more control when holding the scanner from underneath. So this is all with the patient sitting in an upright position, or if the patient is lying down. Again, similar situation. I'm holding the scanner in my right hand in a very loose type manner, loose and free type manner. And I can move the scanner, adjust the scanner position, all in my fingertips. My arm is staying in the same position. Whereas if I hold the scanner in a more firmer grip, shall we say, you can see my hand and my arm extends vertically upwards. And as I need to tip the scanner, I have to lean forward and get my shoulder and get my elbow into that. And again, it's uncomfortable to do as an operator, and ultimately that can translate into the patient's mouth. It's worth pointing out there's no right and wrong. What I'm trying to highlight here is just different techniques. So whatever feels comfortable for you, that works. But just again, be conscious of the fact that there may be some kind of knock-ons from that. Before we start anything when it comes to scanning, we need to tell the software what we want to do. Now we do that through the order form. So what do? We select the lab, we select the indication, we select materials that we require, we select the delivery date. All of this information goes out to the lab. We also specify some workflow specific. So for example, a pre-preparation scan, or if we want to do HD photographs, we'll specify that on this page as well. And that helps us instruct the software as to what we want to do, and the software then will guide us through that particular process. I like to think of TRIOS as a complete system between the scanner and the software, like an automated jigsaw puzzle making machine. So think about a jigsaw puzzle. Normally, what do? We do the outside pieces first, and then we put in all the other bits. And we might have a different strategy. We might like what's going on here, where you add onto the outside pieces. And sometimes people will like to look at the unique components or unique jigsaw pieces and put them together. Do the easy bit first, and then do the harder bit. Scanning is very much similar. The scanner creates the jigsaw pieces. The software puts those jigsaw pieces together. The software completes the outside pieces first, or it's important for us to complete the outside pieces first. And we all know that sometimes some pieces are easier to fit than others. Sometimes pieces don't fit for one reason or another. And sometimes the wrong piece goes in the wrong position. All of those concepts when it comes to jigsaw puzzle translates through to scanning. And hopefully that will all make sense as we go through some more, as we go through the presentation. So let's talk about the clicking noise. The clicking noise, it's a love-hate type thing. Some people love the clicking noise, other people hate it. I think it's wonderful because it's the software communicating to us. It's trying to communicate to us. The software is trying to audibly engage us regarding the scan progress. Ultimately, if the software is clicking, the software is saying, keep going, you're doing a great job. If the clicking stops, it means the software is saying, I'm not sure what's going on here. You got to stop and help me out. Please do not turn off the clicking noise. By all means, reduce the volume, change the type of noise, but please do keep that clicking noise going. So what does clicking noise represent? It's the software saying to us that it recognizes what it sees. What does it see? The lower right hand image is what the scanner sees. And the software says, I recognize that data. I know where to put it. Keep going. So we get a clicking noise, and we'll always get a green box to accompany that too. Clicking is equal to green box. And if we can tune into that clicking noise, it's the only way the software has to communicate with us whilst we're scanning. So definitely tune in, and it will definitely help you improve your scanning game. So why does the clicking stop? It stops because the software does not recognize what it sees. Why does it not recognize what it sees? Well, we'll get a red box. So the reason it won't recognize what it sees is because there are a number of reasons, but one of them is the scanner has not seen that detail before. So, for example, you do your occlusal scan, go straight in lingual. The software hasn't seen that lingual detail before. It may not click. Whereas if we roll over from the occlusal surface, we're adding on that lingual detail, and then we can continue. So the software is always adding on new information to what's already existing. So one reason the software might stop clicking is because it hasn't seen the detail before. Maybe what it sees is indistinguishable from other details. There's just not enough clarity, there's not enough detail in what it sees for the software to be able to categorically say, this is where that data goes. So it may not be 100% certain. And that can lead to a little bit of frustration. You've got the scanner in position. You're thinking, this software should be clicking. It should be accepting that data. I should be allowed to carry on. But the software is a little bit uncertain. The scanner and the software is an expensive, accurate, precise measuring device. We want it to only produce good information. So if there's any doubt, we want to know where the doubt is. And by not clicking, that's the software saying, here, I can't figure out what's going on. Please, I need some assistance. And that can often be down to something has changed within the scan. So mobile tissue, or worst case, if there's an error in the scan. And we'll talk about both of those in due course. So let's take a look at this little video. Can we play? There we go. So what's happening here is I went back to capture the distal of the 8, and in doing so I drifted into attached tissue. As the software captures some attached tissue, but what ended up happening is when I went back onto teeth, came back into the attached tissue area, the scanner had distorted the cheek. The cheek had distorted the attached tissue. So what the scanner was seeing when it went back into the attached tissue area was a different shape to what it had seen previously. Something had changed. And the software stopped clicking. So I observed no clicking, so I brought the scanner back into an area that it would recognize, i.e. back onto teeth, and it was happy clicking. So the key thing is, if the software stops clicking, what do? Move back onto a reference point that's recognizable, let the software click again, and continue on from there. So in this case, I was jumping into the attached tissue zone and back out again to highlight the point. So, golden rule, if the clicking stops, stop moving. Don't turn off the scanner. Hold the scanner steady and assess what's going on. Keep the scanner on. Don't turn it off. Allow the software 3 seconds to restart, to start clicking again. And if it doesn't start clicking again, that's the software really saying, look, I don't know what's going on here. I don't recognize where I am. I can't restart from here. And if that's the case, reposition the scanner in order to restart. Now let's take a look at the distancing. So the scanner should be 1 to 2 millimeters above the surface while scanning. On the left hand side here, I'm showing a situation where actually we're too close, and we often get this on canines. If you're too close, and as you go around the corner, around here where we are with the canines and the laterals, the teeth are actually going inside the scanner window. So we can see that on the lower right hand image. See the way the facial surfaces are grayed out there? That indicates those teeth are inside the scanner window. Now in this case, I'd previously scanned that surface, so it's fine. But if that was my first pass in that area, we would see missing detail and holes on those teeth. So we're going to back off a little bit. Plus, it's going to be a little bit uncomfortable for the patient if you're actually dragging the scanner across their teeth. In this situation here on the right-hand side, we're too far away. And what we're seeing is this grayed out area of the palate. So we can just about see some of the lingual surfaces of the teeth, or the palatal surfaces of the teeth. But that's it, we're too far. So we have a working range of about anywhere from 1 millimeter up to about 12 to 15 millimeters. So in this case, we're quite a distance away from the surface of the teeth. It's going to be easy to maintain a good, consistent distance from the surface of the teeth if you're using your left hand to stabilize the scanner. We often talk about the scanner being like a toothbrush or like an eyeball. It's a little window that the scanner sees out through, the window at the end of the tip. We often refer to that as the eyeball. So that's how the scanner sees what we wanted to see. And it's really important that the scanner is following the shape of the arch. It's looking straight at the surface in question. So there's very subtle differences here between these three images. But maybe let's start on the right hand side. This is right. The scanner window is looking straight at the surface of the teeth. So we're at the position where we're scanning the buccal surface of the premolar and the molar. The scanner is looking straight at it. And we get a nice, clear, straight on view. Obviously, type it onto and intraoral, but the scanner is seeing a nice straight on view. It's looking at the facial surface. You can see some of the mesial, you can see some of the distal, and that's all good. In this situation, the scanner is tipped in a slightly distal manner. And the result is we're only seeing the distal surfaces of the teeth. The mesial surfaces are missing. If we were to complete a full buccal scan like that, we'd end up with gaps on the mesial surfaces. And then the reverse of that then is true in this situation, where we're scanning from a more mesial position. So the scanner is looking from a forward perspective. So we can see the mesial detail of the teeth, but the result is that the distal details of the teeth they're in shadow effectively, and we're not going to capture that information. So it's always important to, as much as possible, have the scanner, that little window, that eyeball, look straight at the teeth. People often talk about the scanner being like a toothbrush. So when we're teaching somebody how to brush their teeth properly, we hold the toothbrush at lots of different angles as we work our way around the arch. Same kind of concept. So the scan strategy. 3Shape have a very specific scan strategy for scanning an arch. And the reason is very simple. It's to ensure accuracy. We can pick up a scanner, we can capture teeth, we can wiggle it around buccal, lingual, occlusal, all the way around the arch if we want to. But that's not the best way of capturing the most accurate scan. So follow the very clear, defined scan strategy, which is occlusal, lingual, buccal. So let's start off with the occlusal scan. Start at the back, pull the scanner out, sweep across, push the scanner back in again. Easy peasy. So you'll, obviously my hand is slightly out of shot there, but you'll be able to see, if we do that again, that my hand hardly moves. Comes out, move the scanner across, and back in again. So if my hand doesn't move, it's easy to do. It's going to be very comfortable for me. It'll be comfortable for the patient. This is what not to do. So we sweep, we're trying to follow the shape of the arch. We have to do it somersault, nearly 180 degrees turn to get back around again. Let's do that again. Here we have to turn the scanner around at the midline and then push back in the other way. That could be quite difficult to achieve. It is very difficult to do that and maintain consistent view of the teeth. Inevitably, the scanner is going to move at that point of rotation. The scanner is going to it's going to move out or in onto the tongue or whatever. There's a risk that the scanner will lose connection, not connection, but the software will not recognize where it is, and we may end up with a red box situation. You know, we'll recover from that, of course, but at the same time, keep it simple. Out, across, back in again. So let's look at the buccal strategy. Start occlusal, roll over, we get the clicking, the scanner follows the shape of the arch. We like to come to the midline, then do the same on the other side. All of the time, the scanner is following the shape of the arch, the profile of the arch. The eyeball is looking straight at the teeth in question. Why do we do it with two teeth? In two passes? Patient comfort. Pulling a scanner out of that buccal cavity is a lot more comfortable than pushing it in. So if we were trying to attempt a single pass, you know, it can be a little bit uncomfortable. That can be difficult for the operator. And also it can increase the chance of an error kicking in. So again, good techniques and so on, and you may master it and you might become greater than it, and that's wonderful. But it's a lot easier to do it back to the midline on one side and from the back to the midline on the other side. Now let's talk about the lingual strategy. So we start off occlusal, roll over, and here I've just taken this kind of angle just so you can see that I'm rolling the scanner as I sweep around so that the eyeball is looking straight at the tooth in question. Therefore being able to capture the full tooth and the distal and mesial surfaces as much as possible. So let's talk about the occlusal scan. Why is it important? Well, any structure, whether it's a scan or a building or a jigsaw puzzle, it requires a solid foundation. If we don't have a solid foundation, we're going to end up with some difficulties. So let's take a look at a good occlusal scan. So here we start off lower left, come out to the anterior region, a little bit of rocking just to get over that incisal edge. And then we push back in again. Nice and simple. That's a good occlusal scan. It's easy to achieve it. Good retraction as we go, good stabilization as we go. And what we get is obviously occlusal detail and some facial detail, some buccal detail, and some lingual detail. Those are the two key objectives. When we're doing an occlusal scan, we're going to capture the occlusal surface, we're going to capture some buccal and some lingual details. Because what we're doing, we're giving a foundation then, a really good solid foundation. When we do the buccal scan, the software has something to stitch onto. When we do the lingual scan, the software has something to stitch onto. Now, this is how not to do it. So, occlusal scan, sweeping around, and this can be just very subtle, and very often just the manner in which you're holding the scanner can implicate this. the angle at which the patient is sitting, how comfortable is the patient, how comfortable are you relative to the patient. And what we're seeing here then is that we captured occlusal detail, we've captured lots of lingual detail, but we've got no buccal detail. Let's just play that again. So you can see we're very lingually biased there, and particularly around the incisors, because incisors tend to be flared out that little bit, we tend to miss the facial detail. But here we've got no buccal detail at all. So we've captured the occlusal surface with too much lingual and not enough buccal. So let's look at the consequence of that. Let's add on the buccal scan onto this. So intentionally, I've done the single sweep on the buccal surface there. And what's happened is you can see that on patient left, everything is stitched up correctly, but then this cracking appearance starts to occur, where the buccal scan is not stitching up correctly with the occlusal scan. There's two different scans going on there. They are not aligned. We see this terrible cracking effect, pretty much starting off from the premolars, working its way all around. And very often we see it getting progressively worse and worse and worse as we work our way around the arch. That is a complete no-no. The buccal scan doesn't attach to the occlusal scan. Don't try and fix it. You could go in and try and rock and roll over those surfaces and try and stitch it all up together, but it's like a building. If there was some subsidence and big cracks starting to appear in the walls, and the builder comes back and with a bucket full of filler and tries to plaster the walls, get rid of the cracks, there's a bigger issue. So it's best just to be brave, delete the scan, and start again. And here are some screenshots from scans that we've received or picked up with our lab customers, about the real kind of thing. Digital scans, digital impressions and conventional impressions, there's no difference between them in terms of we should always review them and assess them before submitting through to the lab. So here we've got a horrific scan coming through. It's very difficult. I probably wouldn't even be able to recreate this type of scan if I tried. And then down here again, we're seeing these kind of crack lines kicking in around here in the incisal edge and in the incisal edge of the lower teeth as well. This is a classic. What we see here, this kind of crack line running along by the canine. What it means is very often when we see it, it's very often due to the fact that the user has done an occlusal scan, perhaps not great, done a buccal scan, worked their way around as far as here, but an error has kicked in, so there's a discrepancy. And then we start at the back on this side and sweep forward, and this side of it might be good, this side of it is bad, but they don't match. And no matter what you do, you try and come forward, you come back, you come occlusal, you roll over, the scanner will just stop clicking at this point repeatedly. And the reason is, it's the message, it's the software saying, guys, I can't add detail in here, there's conflicting information, I don't know what to do, so I'm not going to do anything. And it's up to us as the intelligent operator to spot that and decide to make the call, hit delete scan, and start again. So let's take a look at the buccal scan. So I've shown you how we should kind of move the scanner around to capture the buccal scan. But let's look at positioning. So let's just focus on the lower right hand side here. So I've got three different positions here. So we see too deep into the sulcus, and I'm too high here, and we're scanning across, we're capturing tongue. And the consequence there is that we could end up capturing some artifacts as well. So in this situation, the scanner is positioned well. We can see the whole crown, we can see some of the gingiva. Granted, we're maybe a little bit high. If the tongue was there, we should probably be a little bit lower so we don't see so much tongue. But in this case, the tongue isn't present. The tongue is out of range, and sometimes we might even put a mirror in to pull the tongue out of the way. And all we need to do is get that tongue to 12 or 15 millimeters away from the scanner so it's out of range and it can't see it, and we'll end up with this kind of blacked out area. The scanner can't see it. It's wonderful. So next one, the scanner is too low into the sulcus. We're not capturing all of the crown. and we're capturing too much sulcus, and we're into that area of attached tissue that could be problematic. And then the next option or scenario here is that the scanner is sitting too high, so we're not capturing all of the crown, we're capturing a lot of tongue, and the result is we don't have a complete scan, and potentially we're bringing in some artifacts as a result of the tongue being present as well. As we sweep around, as we're doing the buccal sweep and we sweep around, obviously the scanner is going to retract the cheek. The scanner keeps the cheek out of the way. So when doing a buccal sweep, we do not need to put our finger in to keep the cheek out of the way. Let the scanner do that. Let our left hand just focus on stabilization and guidance. As we sweep around to the anterior region, roll the scanner or tip it up at 45 degrees or so. No precision there needed. But the idea here is that the tip is keeping the lip out of the way. And the result is that the scanner has a clear view of the teeth. And the result is that we have a nice clear image on screen. If we don't do that, if we don't tip at 45 degrees here, I'm just bringing the scanner right across, you can see that the scanner is actually pulling the lip into the scan. Now, best case, AI gets rid of the lip, it's not an issue. But that lip is blocking the view of the gingiva. So it does mean we'll have to rescan that area, get the lip out of the way and rescan it. So try and avoid that. And there may be some scenarios as well where the software brings in some artifacts of the lip. So we want to watch out for that. Buccal retraction. So we're scanning the lingual surface. So we want to keep the cheek out of the way. And that subtle movement there, let's just play that again. That subtle bit of retraction. So initially, you'll see my finger is in there. It's kind of retracting. It's not really. It's getting in the way nearly, more so than anything else. But then I put my finger in a bit more aggressively, maybe move my finger to a different position, move it up out of view, pull it to the side, get the cheek out of the way, and the cheek disappears. So initially, we've got cheek and finger getting into the view. But then as we retract properly, the cheek is completely out of the way. We've got a nice clear view of the teeth in question, and we've no cheek and no artifacts. So this is what we want to see. This is what we don't want to see, and the result of that can be artifacts on screen as well. And plus, the software will be going from green box to red box, clicking, no clicking. So we should really give the software, remove as much kind of variation in the scan as possible. Give the software the best opportunity. When it comes to scanning the bite, very simple to do it right. Very simple to do it wrong as well. There's a couple of key things. Let's work through here. So I start at the molar, sweep forward, the lower arch comes in, and then I push back again to get the upper arch in. On the other side, the arches came into occlusion immediately. I still continued on to the canine. And then when the arches are aligned, quickly review them in occlusion, and we might even use the clearance tool as well to review. And in this case, we see a couple of little blue spots around the arch, and we see the corresponding blue spots on the lower arch as well, indicating the areas of hard contact. So what do we do? Start at the molar. Get the scanner into position. Have it so that we can see some of the upper arch and some of the lower arch. A nice even balance. Turn the scanner on and hold it steady for 2 to 3 clicks before moving. Align your movement with the occlusal plane. So sweep out nice and straight, nice and in a forward manner. And scan only up to the canine. So start at the back, come to the canine. Hopefully at that point the software will align. And in this case we saw that the software aligned the lower arch but not the upper arch. So what we did is we moved the scanner upwards and then pushed back again and captured just that bit more of gingiva information. So two things going on here. We're giving the software a bit more information. We're giving the software a bit more time as well to understand how the alignment should happen. And it does so. As a rule of thumb, we work in 15 to 18 seconds. If the software doesn't align the arches within that time frame, stop scanning, do the manual alignment. When I moved over to the right hand side, the software had instantly aligned to the arches. As soon as I started scanning, look, there's the blue area of the bite scan, ping, lower arch and upper arch came in immediately. You will never take a wax bite on a single tooth, so why should you do a bite scan on a single tooth? So sweep forward, follow the same protocol, go from the canine, go from the molar through to the canine, give the software a nice big long span of information to make sure that we get the most reliable bite. And always review the bite. Always review it, make sure we're happy with it. If not, be brave. Hit delete, rescan the bites again. And it's just the bites, that's all we need to do. Moving on from the static bite that we capture during a standard scan, we've got patient-specific motion. So let's take a little look at this video and see what happens in the lab. Why do we do a patient-specific motion? So this is the lab software where we've designed a crown and run the articulation sequence. And you get to see where you get all the contacts and slidings on the arches, but also on the crown. So blue means sliding, red means collision. Now there's an adapt design button here, so we adapt the design. The software automatically contoured the occlusal surface to get rid of those collisions. And we ran the sequence again, and we can see we have no collisions on that new crown. That's the idea behind patient-specific motion. So in order to capture a good motion record, the patient must hold their arches together whilst sliding. That's key. So training and education of the patient is really, really key here. There's no point in doing it unless we're going to do it correctly. So the patient must hold their arches together while sliding. We would always encourage a clinician to guide the patient and let them have a test run. So don't put the scanner in their mouth. Just show the patient what you want them to do. Ask them to do it. Make sure they can do it correctly. We start from centric occlusion, slide to the right, slide to the left, back to center, slide forward, slide back. And that's it. That's all we need to do. Just allow the patient a couple of opportunities to do that and make sure they're doing it correctly. If they're not, it's fine. Don't worry about it. We'll move on. But if they can do it correctly, it's a great piece of information to capture. So try the test run, then you're going to get the scanner into position. Hold it steady relative to the upper arch because the lower arch is going to move. So we want to hold the scanner steady relative to the upper arch and allow for the lower jaw movement. And try and avoid holding the scanner in a position where it's going to impinge that lower jaw movement. So once we're in position, we're nice and steady. Scanner steady. We start scanning. And you can see both arches must be in view. You can see straight away that as we started to slide, the jaw opened, we got a red box. Now I just subtly repositioned the scanner to avoid that. All that's happened is that the lower arches kind of came out of view. So we do that. Again, 15 seconds or so, that's all we need to do. There's a bit of processing time involved in the software. And once it's done, we get to see, we should play back. Play it back, make sure that we have it. Make sure that we have the detail and that we're happy with it. And we have a show contacts option here at the bottom so we can see where the sliding is occurring. Make sure we have contact. If we don't, delete it. Don't worry about it. Move on. The lab has lots of other tools that they can use, including a virtual articulator. But if we can capture this information, it is definitely the way to go, but it must be reliable. Post-processing. So we've done all of our scans, we're happy with all the detail. We're going to post-process. What post-processing is about, it's finalizing, it's optimizing, and it's protecting your scans. It's really important that this happens. So if you're sending a scan to a lab, it will be post-processed straight away as part of the process. That's a given. If we're not sending a scan for some reason, if we don't post-process it, there is a risk. It's a given, in fact, actually, that data, the raw, unprocessed data, will be deleted through a flushing process within the software after 45 days. So, number one, you will lose your data if you do not post-process. And number two, it'll never be enhanced. You'll never get the final result. So, ultimately, you're going to be sending the scan somewhere anyway, so it is going to be processed. But if you do get a message from the software saying scans has not been post-processed, do you want to do it now? Always hit yes. You'll have an option to post-process within the analysis page here. And as I say, if you scan and you don't send it and you go back to the main menu, the software will come up with a message prompting you to post-process. Here's the difference. Here's a scan before it was post-processed, and here it is after it's post-processed. So we can see there's a huge enhancement of the detail there. The file size is much more manageable as well. So it's a finalized image that we're ultimately getting at the end of the post-processing stage. Let's take a look at some tricky situations. So we've got a situation here. So we've a situation where we've a missing tooth. Through the normal scanning strategy of occlusal, buccal and palatal, there's a strong chance that we're going to miss the mesial detail of the 6 and the distal of the 3. So we need to go back in. We need to go back in and rescan that area. Let's take a look at that again. And you can see the missing detail. We need to get that scanner looking straight at the surface in question. So we're orientating the scanner so it's looking at the distal, orientating it so it's looking at the mesial. And we've captured everything we need. Physically, how are we doing that? So you can see here, I'm holding the scanner nearly in a sideways manner, holding it at an angle, and I'm tipping the scanner, I'm rolling it in my fingers so that the window here is looking forward. So to capture distal of the 3, I'm holding the scanner so it's looking forward. To capture mesial of the 6, holding the scanner, tilting it backwards so that it can see the surface in question. So it's a very obscure maybe orientation of the scanner, but I'm doing what I need to do to get that scanner into position. So holding the retracting tissue, holding the scanner steady, using a finger rest where possible is exactly what you need to be able to be able to capture the missing detail. So it's a combination of physically watching what's going on in the patient's mouth and of course watching what's going on screen. And with good finger rest, with good stability, you can focus on the screen, make your subtle adjustments and make sure you capture what you need to do. Now here's a more complicated edentulous situation. So we've got the two big evils. We've got a tipped 7 and we've got a big edentulous span. So the textbook says that we should start occlusal, do the full occlusal scan and get over here. As we sweep over in this region, the distance from the ridge to the scanner is going to be, could be, if the ridge is quite resorbed, it could be 12 millimeters or so. So we may not even be able to see the ridge as we sweep across. Don't panic. I would always say forget about this. So it's okay to stretch the rules sometimes. My strategy here would be go occlusal, sweep around, go lingual, sweep around, go buccal, and sweep around, depending on whether we've gone as far as the canine or the premolar. We may do it in two passes or maybe a single pass on the buccal. Focus on what we can focus. It's like studying for an exam. Do the easy stuff. Do the stuff you like doing first and leave the hard stuff until later. But actually, when you look at it, the hard stuff isn't so hard after all. So we've captured all of this detail first. Then start here, roll over lingual and ease backwards. And capture that ridge from a lingual perspective. The tip will keep the tongue out of the way, and you're going to use your finger or a mirror if needs be to keep the cheek out of the way. So you'll ease back, you'll capture the ridge on the lingual side. Roll over occlusally on that 7, sweep forward and do the same on the buccal side. You may need to use a mirror to keep the tongue out of the way if the tongue is quite fleshy. And then it's a matter of going back in then and capturing the mesial of this detail and distal. You probably have this distal of this already at that point. And when doing the mesial, you might take a lingual approach and tip the scanner so it's looking straight at that mesial surface, and do the same from a buccal perspective as well. Shade measurement. It's really important. Shade measurement is fabulous. It's within the software. The lab can measure the shade. But the challenge is, as we'll see here, as we take a shade measurement and sweep around the tooth, we'll see lots of variations in shade. So if we didn't specify a shade and we sent that scan to the lab, we're making it quite difficult for the lab because there's such a huge variation there. And ultimately, it's your responsibility as a clinician to define the shade and make sure that that's communicated through to the lab. So what we did, put the marker on, sweep around, get a feel for what kind of shades was there. So there was there's a bit of A3.5, there's more A4, there's a bit of C4, there's a bit more C3. So we rested a marker in an area of C3 and used the Add Extra button and put another marker in place in an area of A4. And generally, we do encourage clinicians as well to offer up a shades tab just to confirm that they're happy that those are the shades. And by you leaving those two markers on and clicking done and hitting send, the lab will see a little screenshot of that information. So they'll see what you have decided. It's your decision. You're the clinician. You've got the patient in front of you. You've got the shade tabs. You're the person making the decision. So it's really important to be careful, to carefully think out what shade selections you make. If there is any graduation, of course, the lab can have access to that and might use it for their own interpretation. But you're saying here that you're happy to go from C3 through to A4. Let's look at one of my favorite tool combinations, which is trim and lock. So we've done a scan, a little bit of blue tack here, simulating some tissue, simulating some blood, simulating some saliva on the margin. We're happy with the rest of the margin and the rest of the prep, but we have something that's getting in the way. So what do we do? So we're going to use the trim tool and delete out that area. So of course, if it was blood or saliva, you could wash it out. Don't go back in and just rescan that area. Trim it first. It's really important that we do. Now the risk is when you do go back in to rescan that area, that if it was saliva or blood, that it could, or indeed tissue, it could have collapsed onto the good margin. So you go back in trying to fix one area, you're introducing another problem. So it's really a good idea to use the lock tool. Use the lock tool, paint onto the area that you're happy with. So you're going to delete the bit you're unhappy with, paint the area you are happy with the lock tool, and then go back in and rescan. And even in this case, I've just repositioned a bit of blue tack there on the palatal surface of the tooth. You can see the scanner sees the blue tack, but it doesn't capture it. So the prep is as good as we can possibly get it. And whether that's you're in a situation whereby you've got some bleeding on part of a prep, you want to address that, or you could have multiple preps, 3 preps. 2 of them are good, 1 needs to be rescanned. Lock the 2 good ones, because ultimately when you go in to rescan the bad one, the scanner will see some other parts of the arch, and you don't want to introduce any other issues. So when rescanning an area, always trim first. Lock the good bits of the margin, the prep, etc. to protect it. Wash, dry, adjust before rescanning, and then rescan without and then rescan. Of course, rescanning without trimming may create artifacts. So it's always important you trim first and then rescan. The zoom feature is a fabulous little tool as well. Sometimes we use it in tricky situations. So if you have a deep, narrow cavity, so we've on this particular scan here, this arch, we've got an inlay. The margins they're quite deep, and we'll use this when it's a deep interproximal margin as well. So there's a zoom feature. You can see there that the image is a lot closer. We've zoomed in, so it allows us to get in and capture those deeper details. So again, stability is really important here because our field of view has been narrowed. If we're moving the scanner in an unstable type way, we're going to have it's going to be difficult for the software to follow us and for us to kind of identify where we are. So keeping the scanner nice and steady is really important to get the best out of this. HD photos, use them as much as you can. So we've scanned our prep, we're happy with it, we can see everything. Why not give the lab an extra bit of information with the HD photo option? So we turn on the HD photo option, we get the scanner into position, turn it on, and when the scanner recognizes where we are, we get a green box, and clicking, push the button again to take a snapshot, and repeat. So on a prep, we'd typically do an occlusal snapshot, a buccal snapshot, and a palatal or lingual snapshot. And that's great for preps, but equally, scanning a patient spots something in their mouth, you could use the feature for the same reason as well, to get that high-def image to either reassure the patient it's nothing to worry about, or indeed to highlight something you've spotted intraorally and you want to get a clearer snapshot of that for the patient. Some do's and don'ts for the lab. So I put a post on one of the 3Shape forums there some time ago and asked, guys, what advice do you have for dentists? And all these posts came back. So it was a big long list of them. And some of them did tend to use some quite colorful language. So make sure that the margin is free of saliva. These are all quite obvious, but it's really important. You get a good scan, give a good scan to the lab, they'll be able to produce some great work for you. So make sure that margin is free of saliva. If you can't see the margin on screen, the scanner can't see it. If you can't see the margin in the mouth, the scanner can't see it, and then the lab definitely cannot see the margin. It's a good idea to turn off the color as well. Sometimes we get to see a better level of contrast when we turn off the color and view the image in a monochrome manner. Get a better sharpness of detail. Always check your bite. Again, just because the software pings the arches together doesn't mean it's the correct bite. The patient could have might be biting incorrectly. So just make sure that that is correct. Always. Make sure to remove additional tissue if it's present. Follow the correct workflow for implant cases. Inform the lab of the scan body type. So some implant questions there. That's another topic for another time perhaps. But when using the scan body for an implant, make sure you tell the lab what system you're using so that they can interpolate that and produce the correct crown with the correct interface on it. A lot of labs recommend, even if it's a single molar, still do a full arch scan, or at least include both canines, because then when they're running the articulation sequence, they'll get the best and most representative guidance. Again, an implant related situation, use a scan body. A scan body is the digital equivalent of an impression post. Do not scan tie bases. We lose detail. It's counterproductive. Always scan areas of missing detail. Again, making sure everything is as complete as possible. Verify the shade, like what we just talked about there a few moments ago. Use a pre-prep function on anterior cases for even if it's just for indication. So some labs like to see this. They like to see what was there before, what worked before, or indeed, why did a tooth fail, so that they can avoid that. So by taking a pre-prep scan, you're capturing the tooth forms before you prep. And that's going out to the lab as well. So again, just even for the purpose of indication, so the lab has an idea what was there before they can propose the new design will be similar to that. And again, you can have a conversation around that. And please, please, please always follow the prescribed scan strategy. So in summary, be comfortable, be stable. How many times have I said that this evening? So please be comfortable and hold the scanner in a nice, steady, stable manner. Don't forget your finger rest. Retract soft tissues always. Follow the prescribed scan strategy. There's a reason why we train people how to scan in a particular manner. Stick with it, please. Engage with the software and listen to it. The clicking noise is the software's feedback to you as the operator. It's really important that we take that on board. And use all of the tools to get the best result possible. So here's a wonderful group of people, and these are all part of the support team at 3Shape, the European support team. They're based in Ukraine, and this is a picture taken 2-3 years ago at IDS. We had the pleasure of spending some time with the guys there. Sadly, with the current situation in Ukraine, they've pretty much all been displaced. Some have moved to different parts of Ukraine, and some have moved out to Poland, and families being split. Anyway, we all know the situation out there for sure. Wonderful bunch of people. These are the people who help us to help you guys. When we can't help you, we're on the phone to these guys, and they're doing an tremendous job at the minute. Despite the situation that everybody's under, they're working away as much as they can to continue providing the support. So I think for all of us, the best we can do is offer some kind of support back, and whether that's through humanitarian aid or whatever it might be. So calling you, if you can, make some kind of donation, charity of choice. There's a ton of work to be done out there. There's a ton of refugees being brought to different parts of the world as well, including here in Ireland. So we're all doing as much as we can. So if you can spare a few pounds, a few euros, a few minutes, please log into any of those charities and make a kind donation. So thanks for your time. I hope that you've picked up at least one or two small nuggets, maybe more than that. Please feel free to reach out to us. Hopefully, I'm sure we've got some of our own customers here, and maybe TRIOS users from other providers as well. Perhaps you're looking at TRIOS and you're trying to figure out if it's the right product for you. But please don't hesitate. There's my email address, mark.barry@esmdigitalsolutions.com, and our UK and our Irish phone numbers as well. So please feel free to reach out to us. So thanks a million again for your time. I hope you have a great evening. And if you have any questions, I'll be more than happy to take them.